Uh, Good morning, everyone. I think we should start on time in order that we'll catch up with all the talks. Today, it's my pleasure to be the chairperson of this talk, which will be given by Dr. Jonathan Hazlehurst. He's a consultant endocrinologist at the University Hospital, Birmingham, UK. Dr. Hazlehurst, he will going to talk about the obesity landscape. Please, Dr. Jonathan.
And thank you so much to the organisers for this extremely kind invitation to present to you today. My name is Jonathan Hazlehurst. I'm a consultant endocrinologist and an obesity physician in Birmingham within the UK, and I run a large obesity service that supports approximately 1,500 patients per year. I'm also a clinical academic with interest in large data sets as well as clinical trials in obesity. So hopefully I'm well prepared and presented today to cover this topic for you. So in terms of what we'll be covering, we'll be talking about the global challenge as it stands. I'll put a bit of a spotlight on some data relating to Bahrain. We'll talk about the causes of obesity. We'll talk about weight loss and regain, emphasizing biology in action. We'll talk a little bit, very briefly indeed, on bariatric surgery, and we'll cover the available medications as well as the challenges within the delivery of these. We'll also cover new therapies and development. And we've got approximately 30 minutes to cover this, and afterwards I look forward to answering any questions. So clearly at the moment, there's a very significant and apparent global challenge in terms of obesity. This slide demonstrates the shares of deaths attributed to obesity in 2021. At the moment, globally, 19% of women and 14% of men live with obesity, with ever increasing prevalence. Whilst deprivation is closely associated with obesity, that's clearly not the case in all nations. It's also worth noting that there are regions of particularly high obesity prevalence, in particular North and South America, much of Europe, as well as the Middle Eastern region and the Pacific. Despite huge national and international attempts to limit the increase in obesity, including widespread WHO initiatives, there's been a continued increase in obesity prevalence. And clearly this is contributing to reduced quality of life, as well as increased risk of cardiovascular disease, as well as many other diseases, and indeed death. In terms of data on Bahrain, if we just focus on some data from Bahrain, from the World Obesity Federation World Obesity Atlas, you can see that there's continued increased projections of obesity prevalence within Bahrain. Now, interestingly, some of the 2024 data from the World Obesity Atlas demonstrates that within Bahrain, there were 1,127 deaths due to non-communicable diseases associated with obesity in 2019 alone. Currently, there's an ongoing increase in the prevalence of obesity within Bahrain, and between 2020 and 2035, this is projected to be a 1.7% per annum increase in adults, as well as a 1.4% per annum increase in children, with costs associated with obesity estimated to be approximately 3.6% of GDP by 2035. So clearly the situation in Bahrain is very significant, as indeed it is in much of the rest of the world as well. Now, when we think about obesity, it's important to realize that obesity is a chronic disease, and central to obesity is the biological regulation of appetite at the individual level. And this is shown at the center of this diagram. But of course, there's a very significant impact of the world we live in, as well as indeed how and where we live on that biological regulation of appetite, whether that be societal influences, food availability and production, levels of activity, access to green space, etc., etc. But at the very heart of obesity is the regulation of appetite within the hypothalamus. And we've known that now for many years. I'm not showing any of the old twins data, for example, but we've known since the 1970s, if not much earlier, that there's a huge genetic component to our body weight distribution. Here we can see from this large genome-wide association study that most of the associated genes with obesity are within our central nervous system, which speaks to the biological regulation of eating behaviors and appetite control. If we take a step further, we know from this study and many others that accumulated genetic risk is very closely associated with body weight. And we know that patients at the most genetic risk when they're studied, for example, as middle-aged adults, are in fact 13 kilograms heavier. There are no slim people in society. If you were to put 13 kilograms of adiposity on them, would they stay slim? And this really speaks to the genetic control of our body weight. So with more genes, of course, there's more risk. Now, weight loss in patients, particularly with severe and complex obesity, is very difficult, particularly if you look at data from services that don't either use the latest medications or very low energy diets. And this is just data that we pulled a while ago from specialist services within England. And it's very concerning. It demonstrates that for patients with severe and complex obesity, even in a specialist setting, only 30% of patients that complete a 12-month program lose 5% of their body weight. So with conventional treatment, only 30% of patients lose 5% of their body weight. And in fact, as you can see from what I've highlighted, many patients drop out of services within 12 months, often citing a lack of efficacy. Now, much of the challenge when we talk about the challenge of weight loss is actually driven by the challenge of weight regain. For example, we know that of patients that lose around 5% of their body weight, 80% or so will have regained that weight within 2 years. In this slide, there's some summary data of different dietary interventions, and you can see significant weight loss at the end of the dietary intervention period. But of course, even though you continue follow-up after the diet has stopped, much of that weight is regained. And that's what patients so often tell us about and experience the difficulties of weight regain. Now, we know that in fact, the response to weight regain is really biology in action. As patients lose weight, there is significant adaptation in the form of a reduction in energy expenditure, as well as change in hormones regulating satiety, for example, GLP-1, leptin, etc., as well as an increase in the important hunger regulatory hormone ghrelin. So as patients lose weight, their bodies are, if you like, in very oversimplified terms, almost fighting back to drive some of that weight regain. And that's why we see this phenomenon of yo-yo weight loss and weight regain. This isn't to do with willpower. This is to do with biology in action. Now, we in fact see the same phenomenon when we look at cessation of weight management medications, or better referred to as obesity medications. So this is data from the STEP 4 trial, which is a trial of semaglutide with a semaglutide run-in period, and after 20 weeks and significant weight loss, patients were switched to either placebo or to continue semaglutide. And as you can see in the patients that continue drug, the weight loss continues. But of course, in patients that regain that lost weight, that switch to placebo, weight loss is regained. And this is a challenge because, of course, by showing that the weight is regained when we stop the medicines, we really demonstrate that obesity is a chronic disease. And if we are going to use medications to treat obesity, they should be medications used chronically, much in the same way that if you stop somebody's hypertension medicine, their blood pressure will go up. Now, I could have shown similar data from SURMOUNT-4 when tirzepatide is withdrawn. So really important to realize that as we stop medications or an intervention, whether that be diet or here medication, weight will be regained. And that really speaks to the fact that first and foremost, obesity is a chronic disease. Now, for the most of this presentation, I'm going to be focusing on medications, but actually it's really important that we not lose sight of the role of bariatric surgery. Now, there are challenges with bariatric surgery. For example, the acceptability at an individual patient level can be a challenge. The ability to deliver services at significant widespread volume to do the certain number of cases can be a challenge as well. But we know at the moment that bariatric surgery is associated with long-term weight loss, significant improvements of quality of life, reduction in mortality, and improvements in cardiovascular outcomes. Here, I've just shown some of our UK data using a very large primary care patient registry, but this data has been around now for many years, and we know that bariatric surgery can be a really useful and effective long-term treatment for patients seeking it. Clearly, that's not to say it's not without its risks, but it certainly should remain a considered treatment option. Now, what we don't have yet is we don't have trials comparing bariatric surgery to the very latest medications. Of course, many of those trials are planned and indeed ongoing. In terms of medications associated with weight management, there are three predominant classes. The only current option approved in the intragastrointestinal medication class is orlistat, which blocks digestion and the absorption of dietary fat. Now, many patients stop this medication because of concerns around oily diarrhea or concerns around flatus, but there can be a significant value to patients that are able to tolerate it, with around 3.1% additional weight loss across a number of different RCTs. Centrally acting medications are used in some services and in some nations. I don't use these class of medications in my own service because they were not approved by NICE. However, phentermine topiramate has been around for quite some time now, as has naltrexone and bupropion. Both work centrally to reduce appetite. Phentermine topiramate shows an additional 8.1% loss, and naltrexone and bupropion shows 4.1% additional loss when compared to controls. But the major class of treatment that I'm going to talk about today are nutrient-stimulated hormone-based therapies, also sometimes referred to as incretin-based treatments, and they're going to form the basis of much of my talk. Now, as it stands at the moment, there are three predominant agents available: liraglutide, also referred to as Saxenda, semaglutide, also commonly referred to as Wegovy, and tirzepatide, also commonly referred to as Mounjaro or Zepbound within the United States. Now, in this very busy slide, I just wanted to highlight two useful figures from excellent reviews by Professor Daniel Drucker, who really is the world leader in this area. But I just wanted to highlight two things, to be honest. I wanted to highlight the really rapid progression from the identification, first of GIP and then subsequently of GLP-1 within the 1970s, right up to the approval of these compounds today in clinical use. And secondly, I wanted to highlight the distribution of GLP-1 and GIP receptors here demonstrated within the mouse brain, as well as the known effects on appetite regulation within the hypothalamus that I'm sure many of this audience will be familiar with. I just wanted to also highlight the impact on the dorsal vagus complex, and in particular the effect on reduced gastric emptying, which is such a key feature of this class of medications. Now, I've shown you part of this slide already, looking at the efficacy of these treatments, and in particular I'm going to talk about liraglutide, semaglutide, and tirzepatide. As you'll know, liraglutide is a once-daily GLP-1 receptor agonist, semaglutide is a weekly GLP-1 receptor agonist, and tirzepatide is a combination therapy which agonizes the GIP receptor as well as the GLP-1 receptor. And the trials I'll particularly be talking about are the SCALE trials, STEP trials, SURPASS trials. Now, in a nutshell, we know that with liraglutide 3 milligrams, around 60% of patients will lose approximately 5% of their body weight. Whereas in the STEP trials, we see around 70% losing 10%. And then in SURPASS, we see in SURPASS 1, we see the average weight loss on the maximum dose is 21%. So we've seen a real incremental progression in these treatments. However, it's not just to say that, for example, everyone might end up on semaglutide or tirzepatide. Absolutely not. There could well be patient-specific reasons to favor one medication or the other. These may relate to tolerability, preference for a particular dosing regimen, availability of medication in particular nations, as well as cost, but also data relating to comorbidities, as well as cardiovascular and renal outcome data, which of course we now have for semaglutide. So if we just work through some of the key studies, pardon me, in this area. First of all, I'd like to just walk you briefly through SCALE 1, which is the pivotal trial of liraglutide 3 milligrams. And the trials that I'm going to talk about today are all trials in patients with obesity, but without coexistent type 2 diabetes. I've purposefully kept the trials focused on the obesity-specific trials. And in SCALE 1, a trial of 3,731 participants, middle-aged, predominantly female, with an average BMI of 38. And this was a 56-week study, and most patients were able to complete the intervention. Now, I haven't gone through the side effect profile in granular detail, but it's worth realizing that 10% or so of patients had to discontinue treatment in the liraglutide group because of adverse events, compared to 3.8% in the placebo group. Now, across all these trials, significant improvements in secondary outcomes, for example, blood pressure, rates of prediabetes, numbers developing type 2 diabetes, but worth realizing there are risks of things like cholecystitis, where the risks are relatively low, and there is a small signal for pancreatitis, although certainly in scale 1, the cases of pancreatitis were evenly distributed, including in the placebo group. If we move on to step 1, which is the pivotal study of semaglutide 2.4 milligrams in patients with obesity but without type 2 diabetes, we'll see that this is a study of just under 2,000 participants, again, middle-aged, predominantly female, predominantly a Caucasian population, again, with an average BMI of 38. In this study, slightly more higher percentage of patients completed the study. Similar rates of discontinuation due to adverse events, and significant improvements in cardiovascular risk factors and function, again with this very slight and small pancreatitis signal. Now, what you'll see now in studies moving forward is the data is often presented. Here we've got in-trial data versus on-treatment data, and that relates to how some of the primary outcome descriptions have evolved to include, for example, intercurrent events that often happen during trials. But the way I look at this data in particular, if we look at the in-trial data in panel C, top right, you'll see that 70% or so of patients losing 10% of their body weight. So a real significant increment compared to what we saw with liraglutide. If we jump to SURMOUNT-1, which is the study of tirzepatide, which, as I mentioned before, is an agonist of both the GLP-1 and GIP receptor, you'll see some of the shared characteristics of the other studies, predominantly Caucasian, predominantly female, middle-aged, average BMI of 38, very, very similar. And again, similar rates of discontinuation. Here we can see that on the maximal dose of 15 milligrams, very large weight loss, averaging 21%. And again, associated with improvements in secondary outcomes, including function. All of these studies include measures of function. One of the interesting things with this study is there's quite a large group of patients with pre-diabetes, and actually 95% normalized their dysglycemia. Again, small signals of cholecystitis, and in this study, pancreatitis evenly distributed across groups, including placebo. So we seem to have seen this kind of incremental increase in weight loss as the therapies have developed and emerged. Now, people will be increasingly familiar with this combination medication, CagriSema, which includes semaglutide, which I've mentioned already, as well as this agonist of the amylin receptor. Now, there were big hopes that this would lead to a real incremental increased weight loss as compared to tirzepatide. That wasn't quite seen in the way it was anticipated to, but there were some quite interesting things about REDEFINE 1, which is the first study of phase 3, of CagriSema in patients with obesity or overweight, but without type 2 diabetes. Now, we haven't got the full paper of REDEFINE 1 yet, but worth noting that actually the kind of top line results, as we call them, the weight loss in patients on CagriSema, 22%, very similar to what we saw with maximum dose tirzepatide. One of the interesting things about REDEFINE 1 was the design of the study. So in actual fact, patients were able to self-adjust their own doses. And at the end of the 68-week treatment period in REDEFINE 1, only 57% of patients were actually on the full dose. Clearly, that could impact some of the efficacy as patients are kind of choosing this, how am I getting on with my weight loss as compared to what's happening with side effect profile. So I think there's plenty more to come in the pipeline from these REDEFINE studies, which will continue at pace across the next few years. Now, the trials have, of course, progressed from obesity trials into cardiovascular as well as some renal outcome data. Now, the first study was, of course, SELECT, and this showed significant reductions in risks of further cardiovascular disease or death. And it's worth realizing in SELECT, these are patients with obesity and coexisting cardiovascular disease, either previous myocardial infarction, peripheral arterial disease, I think previous stroke as well. So this is patients at very high risk of further cardiovascular events. And we can see a significant reduction in risk with hazard ratios of the composite endpoint of cardiovascular disease of 0.8. Now, the focus of my presentation today is on obesity rather than obesity with coexistent type 2 diabetes. And that's why I've shared this pre-specified renal analysis of SELECT on the right-hand panel, but equally I could have presented data from FLOW, which is the type 2 diabetes renal outcome study. Now, as I said, this was pre-specified analysis of SELECT, and it was a 5-component renal outcome, including kidney death, kidney replacement treatment, persistent eGFR of less than 15, persistent reduction in eGFR of 50% or greater, or persistent microalbuminuria. And again, you can see a significant hazard ratio reduction at 0.78 in patients on drug. So we now have data that actually these medications, as well as being associated with marked weight loss, are associated with significant cardiovascular protection, protection from death, as well as protection from adverse renal outcomes. Now, of course, as with all these medications, not dissimilar to what we've seen already with the SGLT2s, these medications have progressed into the heart failure space. And STEP-HFpEF, or heart failure with preserved ejection fraction, is the first such study. Now, this is an interesting study using semaglutide in patients with obesity and heart failure with a preserved ejection fraction. This was defined as patients with an elevated left ventricular end diastolic filling pressures, or BMI adjusted atrial natriuretic peptide values, or patients with a admission to hospital with heart failure in the previous 12 months, but all of whom had a preserved ejection fraction. And in this study, there was a dual primary outcome of the change in the Kansas City Cardiomyopathy Questionnaire Severity Score, as well as the change in body weight. And essentially in the Kansas City Cardiomyopathy Questionnaire, the higher the score, the fewer the symptoms is how it works. And you can see semaglutide treatment as compared to placebo associated with an improvement in that score, which is good to see, as well as associated with reduction in body weight. So now we've got a situation where, at least for semaglutide at the moment, we've got improved cardiovascular outcome data, we've got renal efficacy data, and we've now got HFpEF data. And we can see that now increasingly as the FDA approves these medications across these different indications within the US. We have some additional challenges within the UK, particularly relating to how medications are funded within our health service. Now, it's fantastic that these medications have become available and the data has accumulated at such pace. But of course, there are very apparent real-world considerations that we need to consider. Cost and supply are very relevant, particularly in some healthcare economies. Tolerability is hugely important, as is sustainability. You know, we had this big challenge with liraglutide within the UK, where there was a shortage, particularly related to the company's inability to make the plastic to deliver the medication at sufficient speed to make demand. And we've seen that with other GLP-1s as well. Clearly, there can be unforeseen components as well. Patient acceptance can be an issue. You know, as we develop a greater understanding about side effects and risk, clearly there is a challenge to patient acceptance. Medication adherence is very relevant. So, for example, in a US study, an observational study including real-world data, the patients given tirzepatide or semaglutide for type 2 diabetes, within the first 12 months, approximately 50% of patients have stopped the medication. So that's clearly hugely relevant. And that's very different to the real-world data we see in trials. It's really important that we have appropriate wraparound services so that patients get the best out of these medications and are also well able to manage side effects. That may well be dietitian input, support with physical activity, psychological input especially. Some of that might be delivered digitally. There can be effect on other services as we increase treatment for obesity. There can be knock-on effects, for example, onward referrals to other healthcare providers, sleep physicians, perhaps on referrals to eating disorder services, etc., etc. And then, of course, there's a comparative unknown. That's not something I particularly worry about because, of course, we've been using medicines in this class now for many years in the treatment of type 2 diabetes. Now, before we finish, I just wanted to have a look forward into what's going to be happening across the next few years. Now, clearly there is an enormous interest in the development of obesity, with a number of pharmaceutical companies very active in this space. And as you can see, at the moment, as it stands, much of the agents in development are these nutrient-stimulated hormone-based therapies. Now, given the difficulties of manufacturing these peptide agents, as well as the associated costs, I'm really excited to see the results of the phase 3s that will be coming up from the non-peptide oral GLP-1s. And we should, for example, get the results from Attain later this year. I'm excited about that because they're cheaper and easier to manufacture. So that could be very positive when we're looking at the use of these medications at a kind of population health type level. Now, of course, there's real interest in combination therapies. I've mentioned tirzepatide. I very briefly mentioned CagriSema, but there are other combination therapies in development. Some of you may be familiar with the survodutide trials from BI, as well as the retatrutide trials from Eli Lilly. Retatrutide, you may have also heard called Triple G. Now, these are studies where we'll certainly start to get some of the top-line results, or we've had some top-line results already, but some of the trial papers will start to come out within the next 12 to 18 months. Now, clearly this space is extremely exciting as these medications develop at pace. I should mention thank you to my excellent colleague, Professor McGowan, who gave me this slide as I was preparing for this talk. Now, I think it's fantastic that these medications are now increasingly available, but of course we need to have a system where we can assure equitable access to treatment for patients that need these medications. And of course, as I've always demonstrated to you already, when these medications stopped, there's a real challenge with weight regain. And that's of course very relevant when we look at treating obesity as a chronic disease. Okay, so I thank you very much indeed for your patience. And I hope this is all projected well in this virtual presentation. And I thank you for your time, and again to the organisers for this very kind invitation. And now I invite any questions. Many thanks.
Thank you, Dr. Jonathan, for this excellent coverage of a very popular topic, the obesity. We're having two questions, Max, before we start. Yes, Dr. Ali.
Thank you, Jonathan, for your informative talk. We all know about genetics contribution to obesity, but we see, all of us, that the obesity is increasing tremendously relative to genetic contribution. So do you believe in the epigenetics changing the gene behavior due to the environmental factors and then pass to the offspring? Thank you.
Yeah, so thanks very much for the question. So I guess at the heart of this question is the fact that fundamentally our genetics haven't changed, in many, many thousands of years, but yet the prevalence of obesity increases at pace. The question focuses on epigenetics, which is very real and very relevant. I mean, we see the direct effect of the in utero environment. And actually, if we look at the weight gain across pregnancy in the mother, or even the weight at the beginning of pregnancy in the mother, and then you study the offspring of the adult children. So not studying them as children, not birth weights, but you study the offspring as middle-aged adults. And this has been done in a really nice Scottish study. Actually, it's directly relevant to the weight of the adults, the weight gain in pregnancy, and also it's directly relevant to the cardiovascular risk. So in short, this interaction of the world that we live in and our genetics is hugely relevant. How we're living now is unrecognizable for how we lived, even kind of 20 years ago, let alone 50, 100 years ago. And that absolutely is about the interaction between our environment and our genetics, and epigenetics is a key component of that. So yes, I completely agree with the question.
Dr. Ghazi, can you tell me? Or, yes, sorry, there is another question there.
Thank you very much. Informative talk. Salah Abusnana, Dubai. I just want to ask about probably one of the failures we have when it comes to treating obesity and overweight. The nature of the disease as pathophysiology is multifactorial. And we start seeing now the combination therapy making much better than the single therapy which we used before, because we have to tackle more than one pathophysiology. So do you see from the existing medication, any medication that if we have evidence for that we can combine to tackle the obesity as medical treatment?
Yeah. At the moment, none of the available agents are licensed to be used in combination with another agent. Okay. So, if you're on a nutrient, if you're on a GLP-1, they don't have a license to be used, for example, alongside orlistat at the moment. I suspect that probably won't change because of some of the concerns around side effects. I know that that does happen in some clinical practices under careful medical supervision and expertise. The combination therapy that I'm predominantly talking about is also the combination within one agent, whether that be tirzepatide or whether it be CagriSema when it comes, or triple G. But we will get to a point where we look at different things. Of course, one of the challenges with the medication is it directly helps appetite and satiety regulation, but it's a central component and an important component of obesity. But of course, it by no means tells the whole story. It doesn't treat a person's psychology, it doesn't treat their built environment, it doesn't treat their life circumstance. So it's really important that effective public health systems exist, which is really important, but it's also effective and important that we have that kind of wraparound support, thinking of physical activity, psychological ill health, etc. Just one additional line from me. So since I recorded this presentation, and the situation is so dynamic, we now have a tirzepatide heart failure study for FF and obesity. I didn't mention that because it wasn't available. The paper wasn't out when I recorded this talk, but I know a few people within the audience will have seen that in New England Journal of Medicine weekend before last. So, this just shows what a dynamic, exciting space this is.
Thank you.
Thank you, Jonathan, again, for this excellent coverage and for answering the questions. I'm sure that there are many questions still, but we have to get with the program. Thank you so much.
Thank you very much for the invitation.